before they see me, whereas slow growing means they've had it for maybe even 2 3 years. And if you cut out a benign breast lump, it does not recur. But if you cut out a breast cancer, it can recur. Benign breast disease cannot spread to other organs because it's benign. It just stays there, and you cut it out, you're cured. But breast cancer, if you do not do anything, the cells can grow and spread to other organs, and it can actually kill you. It is a life-threatening disease. In benign breast lump, it is smooth and not so hard. Lump in the breast cancer is hard and irregular. Benign breast disease occurs in young people less than 40 years old, whereas breast in women, most of them, almost more than 85% is common, but breast pain is almost always not a cancer. Okay, now for a breast lump, 9 out of 10 breast lumps are not cancer. For nipple discharge, the same thing, 9 out of 10 nipple discharge are not cancer, and breast pain is almost always not cancer. So benign breast disease is like 9 times more common than breast cancer. These are types of benign breast disease that I will slowly go through. You know, you get all these pictures like this: an abscess, fibroadenoma, cyst, fibroadenomatosis, or tumor, or a cancer here. So I'm going to go through this. Okay, benign breast disease. You can get a fibroadenoma or benign phylloides. It's very smooth, it's round, it's mobile, you can feel it, it's nice and round. You can get fibroadenosis or fibrocystic disease or breast cyst. These are all the same group of conditions which are caused by hormonal changes. Okay? I'm going to tell you the difference between fibroadenoma and fibrocystic disease later. These two are the commonest causes of benign breast lumps. Duct papilloma here is not so common. Duct papilloma, there are 15 ducts that go into the nipple. So if you get a nipple discharge, and it can be a bloody nipple discharge, the commonest cause is actually a papilloma in the duct if it's bloodstained. Otherwise, if it is normal color, it may be physiological. So duct papilloma is also benign, and usually you cannot feel it. It's just like pea size. So these are 3 types of benign breast disease. This is the difference between fibroadenoma and fibrocystic disease. Fibroadenoma occurs in young women, usually teens and 20s. If I see a young girl who's 18 years old with a breast lump, even before I examine her, I'm pretty sure it's a fibroadenoma. It's mobile and smooth and has been called a breast mouse because you have to really catch it. It sort of moves very quickly around, and usually in the same quadrant of the breast, but it's very mobile. It does not turn into cancer, and surgery is optional. I advise surgery if it's more than 3 cm. And some of them can grow very fast. So I would advise surgery if it is rapid growing, more than 3 cm, because there is a little small, like 0.05% chance that it may turn into cancer. So small that you actually ignore it. Fibrocystic disease is also called fibroadenosis. It can present as a cyst, which is water, or it can present as a vague lump, lumpy breast, and it usually causes pain in the breast, especially before the periods. So this occurs in women in their 30s and 40s. So it's an older age group compared to fibroadenoma, usually in pre-menopausal women, because after the menopause, you don't have hormones anymore. So fibrocystic disease should subside, because fibrocystic disease depends on the hormones, changes in your hormonal levels, which only happen if you're still having your periods. After menopause, you have no more hormones, so this should stop. And just to say that if it's just a pure cyst, which I will tell you about later, is totally harmless. Now, breast abscess is infection. It's like a big pimple in your breast. Okay, it usually occurs during breastfeeding, but sometimes even those who are not breastfeeding can get an abscess, which may be due to other things rather than breastfeeding. It's painful, and you can see like this picture here is can point like the skin will turn red and it can almost rupture by itself. So sometimes you can see this here. If it ruptures, the pus comes out and then it will get better. To help it to rupture, the surgeon can just cut, call it incision and drainage, let out the pus, and then just do a dressing every day until our abscess cavity gets smaller. So how do we differentiate benign from breast cancer? When the woman comes with a lump, all medical students are taught triple assessment. If they are medical students, I'm sure you know about triple assessment. There are three things: clinical assessment, imaging, and biopsy. Clinical assessment is the history and physical examination. So from the history, like I told you just now, you would have an idea whether it's cancer or not. If it is rapid growing, if it is painful, and especially near periods, it's more likely fibrocystic disease. Or if it's a 20-year-old girl, it's not likely cancer. Clinical assessment includes clinical breast examination, where the doctor examines your breast and feels for any lump. It could be a lumpy area than a lump. They look for any nipple discharge. And also, we also feel the lymph nodes in the armpit to see if there's any enlargement. So clinical breast examination is what all doctors are trained to do. Imaging means x-rays and biopsy is the final conclusive evidence whether this is cancer or not. So clinical assessment by surgeon, imaging by radiologist, biopsy read by pathologist. So there are three people very important in telling you whether it's benign or malignant: the surgeon, the radiologist, and the pathologist. Of course, the pathologist is the most important because biopsy is the final diagnosis. Okay? What it shows. So imaging is mammogram and or ultrasound. Mammogram are for those above 40 with a breast lump. Ultrasound below 40. But what we do really depends on the clinical situation as well. Mammogram is when you compress the breast between two plates, and these are x-rays of the breast. And from these x-rays, you will get an idea whether it is cancer or not. Ultrasound is using sound waves. There's no radiation involved. This is the probe and this is the television screen. So they run it and they look for any lumps. These are mammogram pictures. Now a benign lump is very smooth and round like this one. A cancerous lump is irregular like this one. You know, they call it speculated because the margins are a bit like sharper. And a malignant lump also has what we call microcalcification. You see my pointer here, those white calcification like thing here, the very dense white thing, these are called microcalcification. So if it's clustered like this, pleomorphic, very suspicious of cancer. So the radiologist will look at this and they will tell whether or not this is like a cancer or not.
Okay.
That's a question. I take questions as I go along. For the clinical term of fibroadenosis, because this is just I think this is like a very old-fashioned term that's probably been around for over 100 years or something. Okay, so that's a question I will take as I go along. Breast ultrasound is this thing, you know, you capture this. Oh dear. What happened? I'm sorry. Can you hear me, Eugene? Because
I can hear. Can hear you.
But I lost my screen.
Maybe
I will share my screen again.
Just click it again.
Okay, I got it back. Yeah, sorry. Okay. This one is my fault because it got a message. My internet is unstable. Can you see me again, Eugene? The sides?
Can see and can hear.
So a fibroadenoma is oval in shape, very smooth margins. Now, a cyst and a fibroadenoma feel the same clinically. They are smooth and round. But a cyst on ultrasound is homogeneously black like this, and there's this white shadow underneath. So the radiologist will report this as a cyst, and this one as a fibroadenoma. So if I see this and this, I say this is, your lump is not a cancer. Occasionally, even women in their 40s can get a fibroadenoma. Okay, and occasionally even a girl in her 20s can get a cyst. So the ultrasound is very important in differentiating cysts from solid. A mammogram cannot differentiate from solid. This one may also be a cyst, but in ultrasound will tell us that it is a cyst or a fibroadenoma. In breast cancer, the lump on ultrasound is irregular and it is tall, you know, from here to here, taller than wide, whereas a benign lump is wider than tall. Okay, so this are the features of cancer and the biopsy. The biopsy will conclusively tell me that this is not a cancer. So there are 3 types of biopsy. 1, fine needle, 2, core needle, 3, excision biopsy. Fine needle is actually cheapest because you just use a normal needle you use for taking blood. You put it in and you suck out some cells, and then you put this onto a slide. And then you send the slide to the lab. Okay, and maybe a few days you get the result, whether it's benign or cancer. But this one needs a good cytopathologist. Almost all pathologists can read histology, but not all of them can read cytology. I'm going to show you what cytology is in the next slide. A core needle biopsy is more expensive because now the needles that you get, like this one here, there's a barred needle. It costs like almost 300 ringgit, just a disposable needle. And you can do ultrasound guided. This is the ultrasound, and this is the needle. So you can see the needle going into the lump on ultrasound. So this is more specific. So if the lump is small, an ultrasound guided biopsy is more accurate than if it is a freehand biopsy. It needs local anesthesia because the needle is bigger. Okay, so this is more expensive, needs any pathologist can read it. This is less painful, cheapest, but it needs a good cytopathologist. Now, excision biopsy is the last method where you actually cut out the whole lump. I'm going to tell you what excision biopsy is later. In this general anesthesia is more invasive. And if cancer is found, it needs another 9. We can do this because this is therapeutic. But excision biopsy is not recommended if you think a lump is cancer, because it is in all the guidelines that if you suspect cancer, a needle biopsy is the standard of care, not an excision biopsy. So you know it is a cancer. Histopathology, you have actual strip tissue, a biopsy. So this can be read by every. The advantage of this, if it's cancer, is that you can also do special tests on it. Okay. That's another question. So in most clinics, they will use the term fibroadenoma. Yeah, scientific medical term. Okay, breast mouse is a very lay person term. Okay, I hope that okay. That is not right. You know, people will look at it and say, "What sort of doctor is this?" You know, so of course, diagnose you put fibroadenoma, not breast mouse. Okay, so. The next step, this is operations for benign disease. So you can have excision of lesion of the breast. That's the term we use. That is the code, but actually we can also call it excision biopsy. Wide local excision is when we take out the lump plus a margin of normal tissue. We do this for cancer and also for this benign tumor called phylloides tumor. A benign phylloides tumor is advised to do wide local excision because it can recur if you just shell it out. Because fibroadenoma is very easy to remove, you just sort of shell it out. The other one I'm going to talk about is if you find a lump on mammogram or ultrasound that you cannot feel, the patient wants it out. There are some patients who will want a lump out even if it's not cancer, even if they do not feel it, because they don't feel comfortable with the lump in the breast, even though it's very small. So this one is when we use the guide wire to localize the lump, and then we take it out. I'll talk about this later. And microdocectomy is surgery for a nipple discharge, because this one just means removing the duct. And of course, breast abscess, we just drain the abscess there. So you just now, if there's an abscess, we just cut into it and let out the pus. And operations on nipples are a bit many types, and I'll talk about the nipple thing later. So the commonest operation is excision of lesion of breast, usually for fibroadenoma. It may be multiple. If two lumps are excised with different incision, oh, sorry, this is just, I was doing this for the insurance. Because for insurance, you take out one lump, the second lump is 75% of the cost of the first operation. And if you have two lumps close together, you can take it out through one incision, then the second lump will be 50% of the first operation. Okay, so normally if you have a fibroadenoma, if it is like here, away from the nipple, you want a nice scar. A nice scar is to take the lump through this periareolar incision, because when you close it, you can hardly see the scar. But if you have a lump that's quite far from the nipple and small, you cannot take it out through here, then you have to cut over the lump itself. So this is the commonest operation, okay? And wide local excision is carried out for a benign lump if there's any suspicion of cancer. A 1 cm margin of normal tissue around the lump is excised. Okay, now this is guide wire excision of a lesion of the breast. So you see this little thing here, it is not cancer, but the woman wants it out. We cannot be so cruel as to say you cannot have it out because you can't feel it, because psychologically she would want it out. So what happens is that the radiologist will insert the hook wire under ultrasound. See, this is a hook wire. And then after that, we put the patient under general anesthesia. I will follow the wire in. You see this, the wire, I'm pulling on it and it goes to the lump here. And then I will take this out to throw it away, because medical legally, you cannot throw things away that you take out. You might think it's not a cancer, but you can't tell, you know, there's still a 0.01% chance that, you know, it is a cancer. So if you throw it away and don't send to the lab, you will lose that information. Okay. Now, let's say the lump is not seen on ultrasound, but it's only seen on mammogram. That's even more difficult. You look at this. This is a cluster. It's suspicious of cancer. Let's say the biopsy shows it's not a cancer, but the biopsy may be wrong, isn't it? Biopsy, even under ultrasound or whatever, can be 99% accurate. There's still a small 1% chance it may be a cancer. So we want to put this hook wire into this thing. So we have to use a stereotactic equipment, which comes with a mammogram. This one costs the same as a mammogram. So to do a stereotactic biopsy is like 3,000 ringgit, you know, because it's expensive. So to take it out, the patient has to be on the mammogram. You look at this. So the idea is, this is the window, is to get the needle into the hook wire. I don't know whether you can see the red dot here. This is where we are going to put the needle in, okay, under stereotaxis. This is very technically challenging and is done by the radiologist. So after that, we can do a mammogram, make sure the hook wire is really where we want it. Same way, we follow the wire in and take out the lump. Hopefully the microcalcification is inside. And we send this specimen, this is the breast lump, to check that the microcalcification is removed. This is again also is medical legal, because you cannot feel this thing. You have to show this to make sure that the lump is really, the white dot, sorry, is not a lump. Those microcalcification is really removed, because your hook can be somewhere else and the surgeon depends on the hook to be in the correct position. So I have to trust the radiologist to put it in correctly. And in the same way, the pathologist has to trust us that we have actually removed it, because he's got to section the whole of this to see what these little white dots are. Now, I'm going to talk about nipple discharge. Nipple discharge is very common. It's almost always benign. If due to cancer, it's usually bloody. Usually the colors can be light brown, yellowish, greenish, dark brown, you know, everything. And it can be one side or both sides. If it is both sides, it's usually not cancer. It can be from multiple ducts or one duct. There's about 15 ducts that go into the nipple. So one of those 15 ducts can be discharging or more. If it's more, multiple ducts is usually not a cancer, but a generalized thing. Because sometimes if you have, of course, if you are breastfeeding, there'll be multiple ducts and there's milk coming out. But there's this condition called prolactinoma, where there's a tumor in your brain that secretes prolactin, which can cause nipple discharge. And it's multiple ducts on both sides. There are certain drugs that you take that can cause nipple discharge, like some of the antipsychotics or some of the drugs for abdominal pain can also cause nipple discharge. So when there's nipple discharge and it's multiple, bilateral, we have to take a history about what drugs they were on or what other medical problems they have. So as you see, there's 15 to 20 ducts that open into the nipple. The commonest cause of nipple discharge are hormonal changes. Sometimes before your period, you can get nipple discharge. I can tell you those radiographers who do mammogram, when they squeeze the breast between the two plates, a lot of women actually will get a bit of discharge coming out. That's physiological discharge, okay, hormonal changes. Duct ectasia is the condition where your ducts are dilated. Some people think it's due to aging, it might be due to smoking, nobody knows. Duct papilloma, which I talked about, where there is a little growth in one of the ducts, but very rarely it could be cancer. They say that if nipple discharge is due to cancer, it's usually bloody from one duct, and of course in an older woman. Now, breast pain. Oh, breast pain is so common. Almost every woman will feel breast pain in her life, and women are very scared of pain. They can have a breast lump. If it's painless, they won't come and see the doctor. But if they have pain, even though there's no lump, they will come running to see the doctor. But I always tell them, if it is pain, it's usually not cancer. And it's very common, especially with premenopausal. It doesn't occur post-menopausal women. So due to hormone changes, the pain starts 2 weeks before menses and it subsides after the menses. And the pain can be only one side. When I tell them it's hormonal changes, they say, but it's only one side. But I tell them it can be one side. It need not be both sides. Of course, if you have breast pain, you have to check. It could be due to infection. Mastitis just means infection in the breast or the breast abscess. This again is usually during breastfeeding. But of course, some very rarely, not breastfeeding, you can also get an infection, especially in diabetics, you know. Let's talk about nipple changes. Now, nipple retraction is something that's always mentioned as one of the signs of breast cancer. You can get congenital nipple inversion. They don't call it retraction, actually, it is congenital, they call it inversion. You can be born with the nipple inside. And this one is because the ducts are very short and it pulls it inside. Okay, so this one is congenital, it's not a problem at all. Sometimes it may come out, but most times it stays inside. The only problem is you might have problem breastfeeding, that's all, if you have nipple inversion. Now, the acquired nipple retraction can be a sign of cancer, like these two patients. These two patients have cancer. You can see when it's retracted, the whole nipple sort of pulls inside. And in this woman also, as well as nipple retraction, she also has retraction in the skin. Okay, so these are very obvious cancers. Early breast cancer, you won't get nipple retraction. Early breast cancer, it is early breast cancer. Actually, the breast looks absolutely normal in early breast cancer. The nipples are normal, the skin is normal. And that's what you want to catch. You just want to feel a lump before it gives you these problems. Now, nipple changes. There's a difference between eczema and Paget's disease. There was a WhatsApp thing going around that's a nipple itchy, nipple ulcer could be cancer. And then all these women with the itchy nipples will come running to see me. It's not just itchy, you know, there has got to be an ulcer. Now, eczema is also common, but eczema is due to a skin condition. I'm sure you know what eczema is. It is atopy. That means women who are prone to allergies can get eczema. It usually occurs in the flexors of the hand, arms, and in the fingers. In the breast, it starts at the areola. Okay, whereas Paget's disease starts at the nipple. So a very important distinction. So Paget's disease, you know, in the MCQs, they always say Paget's disease always indicates an underlying breast cancer, true or false. Actually, you have to say true, you know, because Paget's disease is an actual histological diagnosis. If you biopsy it, they show Paget's cells, and then you would know there's an underlying cancer. Now, I've seen this woman with severe Paget's disease where the ulcer extended all the way out before she actually came to see the doctor. Even though it was so extensive, it was still Paget's disease with ductal carcinoma inside too. Paget's disease, the cancer is in the ducts, you know, in the breast ducts, and it sort of migrates up the ducts into the nipple and sets up this reaction, which we call Paget's disease. Okay? So Paget's disease can be a sign of very early cancer, but if you get a accompanying lump underneath, then it could be a late breast cancer. So very important to distinguish eczema from Paget's disease. Eczema, usually bilateral, they will have a history of eczema elsewhere in the body. So this is my last slide. That was quite fast. The take-home message is benign breast disease is 9 times more common than breast cancer. Okay, please consult your doctor if you have any concerns about your breast. Okay, so I end my talk here, and you can, shall I stop shares? Oh no, I have stopped screen share, and I'm happy to take any questions. If there are any questions, you can put in the chat group. Okay, I see one question. How is diabetes related to the breast? Oops. Now, if you have diabetes, you are prone to getting this infection called a carbuncle. Carbuncle is basically like abscess in the breast with multiple cavities in the breast. It usually occurs in the back, okay, in the nape of the neck, but it can also occur in the breast. Okay, so you can get this carbuncle in the breast. There's another condition called diabetic mestopathy. Okay, there's this condition, and if you do a biopsy, it is called lymphocytic mestopathy. And I have seen this before. I have patients who have this On mammogram and ultrasound, it looks like a cancer, but when we do a biopsy, it's put down as lymphocytic mestopathy. And if you look up the literature on lymphocytic mestopathy, it's usually associated with long-standing diabetes. Extremely rare, presents like a cancer, but conclusively diagnosed on pathology, not cancer. And I've seen patients, I just have one patient had lymphocytic mestopathy one side, she's a diabetic, and then later she developed lymphocytic mestopathy in the other side. I would biopsy them to make sure because it really looks like cancer. So these are two conditions in the breast you can get in diabetics. Oh yeah. Yes, I'm not showing the slides anymore because I'm not screen sharing anymore. I finished. That was the last slide. Okay. Any other questions?
I've always wondered, animals like cows and sheep have so many breasts, but have they ever been documented to have breast cancer?
Wow, we have to ask a veterinary researcher. But you know, the animals get the same disease as humans, so obviously they would be documented. But whether or not they have increased risk because they have so many breasts, I don't think everybody knows. Okay, there's a question here. How early do you recommend women to go for screening? How early? Okay. Now, screening is a very emotional issue. When you say screening, is looking for asymptomatic disease. That means the woman has no symptoms. I mean, this WHO, they are doing a global breast cancer initiative where we talk about early detection. By WHO definition, we talk about early diagnosis, detection of breast cancer, which is divided into early diagnosis, which is looking for symptomatic disease, and screening, which is looking for asymptomatic disease. When you looking for symptomatic disease, the woman already has a symptom, even though she may not know it. So breast self-examination, clinical breast examination is actually early diagnosis because it's looking for a breast lump that the woman doesn't feel. And the latest study in Mumbai shows that clinical breast examination in women above 50 years old as a form of screening, screening has caused a 30% reduction in mortality from breast cancer, but only in the older age group, which is the same as mammogram. So they're talking about early diagnosis of breast cancer in the absence of a mammogram program. In Malaysia, there's no population-based mammography program. And even if there is, when do we start screening? Because mammogram in the younger age group, below 40 years old, is practically useless because the breast is very young and it's dense. And so nobody does mammogram screening below the age of 40. Even the US Preventive Task Force now recommends screening every 2 years from the age of 45 for mammographic screening. In UK, they do mammographic screening from the age of 50, okay? But then in Malaysia, they say that the prevalent age group, that means the commonest age group for breast cancer is 40 to 49 years old. So we should start screening, that means looking for asymptomatic disease.
And also endometrial something.
But 40 to 49, the evidence is that screening mammogram does not really cause much reduction in mortality from breast cancer because you can miss a cancer when you do mammogram too young. I have seen so many mammograms in women with breast cancer where the mammogram is reported as normal because the mammogram was dense. Dense means the X-ray, the mammogram, the tissue looks very white. Cancer is also white on mammogram. So white on white, you cannot see the lump, okay? So that's why screening is an emotional issue. It's a patient's choice, okay? But I have women who actually do screening. Usually it's the women who are very anxious who do screening. They screen for everything, not just breast. They do blood tests, they do pap smear, they do everything. So that's why these screening centers like PEF Lab and EP Lab, all those, they have screening packages. They make a lot of money from anxious women because they screen them from top to toe. Okay. The another question is, if there's eczema on the breast, is this itchy, and what is the complication? Now, eczema in the breast usually is in the areola. Of course, it's very itchy. That's why they scratch it, and that's why it starts bleeding. And then it's like eczema in other parts of the body, you know. Sometimes they will get wet and then will be dry. The complication, you can get secondary infected because there's open wounds. So if there's eczema, they have to actually try to keep it dry and do not scratch. And you can use steroid cream on it. It usually works quite well. I see a lot of people with eczema in the areola who see me because they're scared it's cancer. Once I know it's eczema, we usually refer them to the dermatologist. Okay. So that was the question. Any more questions on the chat? It's very convenient to ask questions on the chat. Okay.
Any more questions?
If there's no more questions, I will say my goodbye now because I have another meeting to go to. Okay. So thank you very much for inviting me. I really like to give lectures like this for tailors. Next time, Eugene, you must organize one for medical students. You tell them about career choices after medical school. We did one for the College of Surgeons meeting. I think that was quite well attended by the medical students, because at least now they know they have a choice of careers, not just in medicine. Okay.
Okay. Thank
All right.
you very much, bro. Thank you. Thank you. Thank you. Thank you.
There's three more.
Okay.
Oh, very okay. Career choice for med students would be great. That would be great. The career. Oh, they are all supporting the idea of career options. Okay, so there's something for you to organize, Eugene.
Okay. Thank you.
All
Thank
right.
you. Thank you, Prof.
Bye.
Thank you. Thank you very much, Prof. Yip.
Okay,
Thank
no
you.
more messages. Goodbye. Okay, goodbye.
Thank you.
Thank you. Thank you.
Okay, thank you very much. I think Prof. Yip has left, and I think that was an informative session for all of you. And I think it's a privilege to get people like Prof. Yip to speak to us, because she is a recognized expert in breast cancer and a very eminent surgeon in this country. Our second speaker is known to all of you. I think all of you know him very well. Associate Prof. Eugene Leong. And he is going to speak to you today about early detection and management of ovarian cancer. So without further ado, I will ask Prof. Eugene to begin his talk, and also thank Taylor's University Medical Society for the work that they do in organizing these sessions, as well as many other sessions to increase our footprint in the digital space. Thank you.
Thank you. Thank you. Okay. Thank you. Okay. Can we share, please? Okay. Actually, we see a lot of women with ovarian cysts, and there are a lot of women who have got scans done by general practitioners and from radiologists and from screening centers, and there are a lot of women diagnosed with ovarian cysts, and they're always worried at the back of their mind whether they have ovarian cancer. Next slide, please. Next slide. So I've done my training in Singapore in gynecology as well as laparoscopic surgery, and I run my own clinic as well as I operate. Next slide, please. Next slide. Oh. Well, about 2 months ago, a very close friend, the wife was admitted as an emergency for intestinal obstruction. And during the surgery, they found that there was widespread ovarian tumor. And there was severe pain. She had emergency surgery and she ended up with a stoma. Next slide, please. She has recovered from surgery and she just had her second cycle of chemotherapy, but she also had some other problems like portal vein thrombosis and jaundice, and wasn't able to take the complete set of chemotherapy due to this. So ovarian cancer is there, and we will see it once in a while, and the prognosis is good if it's discovered early. That's why when we talk about early ovarian cancer, it is very important not to miss the fork in the road, so to speak. Next slide, please. Next slide. Now, this is a picture of somebody with an ovarian cyst that I did in my clinic. It looks big. It looks inhomogeneous. It doesn't look like a simple ovarian cyst. Next slide, please. This is another patient with a scan done in my clinic. And there's a uterus there, the bladder there, and there's a cyst behind, right? There's a cyst behind. And again, the question arises, is it benign or is it malignant? Next slide, please. This one is another scan done, and it shows the bladder there, and there's a uterus in the transverse section with a mass beside it. Again, the question arises, is it cancerous or not? Next slide, please. So ovarian cancer, unfortunately, usually presents in stage 3 or stage 4 because its symptoms are very vague and not specific, and they often present late, like with intestinal obstruction, severe bloating of the stomach with water and ascites. And by that time, it's very late stage already. The cure rate will not be as good as if discovered in stage 1 or stage 2. Next slide, please. But the scientific problem is screening and early detection of ovarian cancer has not been proven. And there have been hundreds of studies done which tried to detect early ovarian cancer. So far, we have not been able to discover in pre-invasive stage of ovarian cancer like CIN1, CIN2, CIN3. And many studies have been done in UK, in US, in all over the world, comparing ultrasound alone, comparing ultrasound with CA125, ultrasound with CA125 and Doppler, vaginal scan, many other tumor markers, but they haven't found the correct answer to detect early ovarian cancer, unfortunately. Next slide, please. Now, like in invasive cervical cancer, there is a pre-invasive stage. If you get CIN1 or CIN2, it's still pre-cancer, and there are many things you can do, but not for ovarian cancer, unfortunately. All right, next slide, please. So when we do ultrasounds as gynecologists, we see many shadows, and some of them can be confusing to the patient, because it could be due to benign causes, endometriosis, could be due to tuberculosis, can be due to maybe she didn't go to the toilet to pass motion for the past 5 days, can be due to so many reasons. So therefore, there is a certain limitation to the findings of ultrasound. Next slide, please. Now, physiological ovarian cysts are very common, especially among the younger women, right? This is a typical person, 37 years old, 3 children, had a routine scan, found a cyst, which is still small and simple with no solid elements. And the rest of it doesn't sound suspicious. And a scan done later shows that it's become smaller. Next slide, please. Madam Betty, second example. Next slide, please. She has got, she's a bit older, 55 years old, 4 children. Routine ultrasound of pelvis shows the left mixed solid ovarian mass measuring 7 by 8 by 9 cm. And there's free fluid with floating bowel seen. The cancer marker is not very high, just slightly elevated at 75. The normal is less than 36. And she's got just mild pelvic symptoms and pelvic fullness. Has she got cancer or not? That is a magic question, yeah? Okay, next slide, please. Next slide. Now, Madam Chalaya, a bit older, 72 years old, one child, presented with severe abdominal distension. The cancer marker is very high, 770. It's a multiple mixed echogenic masses with solid elements, with papillary projections, and a omental kicking scene. This is not bad. This one's really no good, and this one may probably be cancerous. Next slide, please. So this is a picture of a patient I operated on, which a very large unruptured ovarian cyst, who presented with a severe abdominal pain. Next slide, please. This one is a person who has got a different kind of ovarian tumor. She is actually a real patient. She's 40s with one child who is quite old already. She had irregular periods, and maybe she only got 3 or 4 periods in a year, for the past 5 years. She had some discomfort in the left side of the abdomen for the past 2-3 years, but she didn't want to do anything. We resaw the mass. And then finally, the pain became more severe. She decided to have a laparoscopy done. We did a biopsy. It came back as an androgen secreting tumor. And then she subsequently agreed for a full operation. And we removed the tumor on the left. And then after that, she ovulated on her own and conceived another child. And the child now is about 1 year plus. And because of the androgens produced by this tumor, she couldn't ovulate, and there was no periods. So sometimes ovarian tumors can present in many ways. Next slide, please. Whenever we get referred a patient for an ovarian cyst, there are many things that we need to do, because as we know, it is very hard to identify by the tests that we do, including CA125. So we need to take a detailed history. We need to spend time with the patient. Next slide, please. We need to examine the patient carefully, systematically. The blood pressure, the cervical lymph nodes, the heart, the lungs, the breast, the abdomen, you name it, right? Including a private internal examination and a pap smear. Many patients always ask, doctor, can my pap smear detect ovarian cancer? Actually, the answer is no, right? But once in a while, we can get a bonus if we can detect certain abnormal cells on the pap smear, but that is not the norm. Next slide, please. When a patient has got ovarian tumor, they will have a very distended abdomen with water, ascites, we call it. They may have water in the legs, edema. They will have got some water in the lungs. Sometimes if it's very severe, they may look very thin. They have lost weight, maybe 5 kilos over the past 3 months. They may have enlarged lymph nodes. They may have enlarged groin nodes. And when we do a rectal examination, when we do to look at the back passage where they pass motion, there's a mass felt. Next slide, please. And of course, when we do an internal examination, when we do a speculum and vaginal examination, we look for mass, whether it's fixed, whether it's painful, whether it's hard, and whether it's stuck to any other organs. Next slide, please. Once in a while, we do have patients who have got double problems. It's not just the tumor alone or the ovarian mass. They may have got a breast swelling, a thyroid swelling. They may have fibroids. They may have got some breast lumps and certain other things. So we cannot just look at one thing alone. We have to look at the overall patient as a whole, and so that we can deal with the problems during the operation and not discover it after the operation. Next slide, please. Very often we can get patients coming in with just an elevated CA125. They have gone to see 6 doctors, and you're the 7th doctor to see them, and they are very, very anxious already because everybody is telling them cancer marker that is elevated is bad. But there are many causes for elevated cancer markers. For example, early pregnancy. It could be, for example, hepatitis, cirrhosis, endometriosis, and many other causes, endometrial causes that can cause it. So we have to rule them out one by one. Next slide. So elevated CA125 alone will make us become very careful, and we will have to be very careful with what we do because we don't want to miss a diagnosis. Next slide, please. Okay. Next slide. So we have to assess all the systems. Next slide. Now, there is something called primary peritoneal cancer, where the cancer is from the lining from within the abdomen, from within the stomach, that has got the cancer, where the ultrasound on the ovary is normal. The CT scan will show that the ovary is not enlarged and is not irregular. And I have seen patients with tuberculosis of the pelvis where the cancer marker CA125 is very high. And the ultrasound finding is exactly the same like ovarian cancer, but they actually have tuberculosis of the pelvis. And these usually do not need operation. So we have to be very careful and we have to be able to tell which is which. Next slide, please. So we cannot just depend on CA125 alone. Neither can we depend on ultrasound findings alone. We have to take the whole patient as a whole from the history and examination. And we may have to do other things like risk of malignancy index, other tumor markers, vaginal scan, CT scan, and magnetic resonance imaging, as well as checking all the systems. Next slide, please. Of course, we mustn't forget all the other basic tests, full blood count, renal function, liver function. Is the kidney swollen or not? Sometimes when we look at it, when we do a scan, if the kidney is swollen, there's a huge mass down there, then we know this is not a simple mass. There's something else, And the chest X-ray can tell us whether there's any lung nodules in the lung. Next slide, please. So there are a few other tumor markers. Some of them can be elevated together with the cancer marker CA125. If we look at the CEA, the carcinoembryonic antigen, it is supposed to be related to the intestine, the large intestine. But once in a while, because there's cancer infiltration into the large intestine, the CEA can also be elevated. CA19.9 is also supposed to be related to pancreatic cancer. But we also have seen patients where the CA19.9 is elevated because, not because of pancreatic cancer, but there's some abnormality in the ovary which triggers it off. We cannot explain to you why, but it can happen. Same like alpha-fetoprotein and beta-HCG. So sometimes we have to do a few tumor markers and not just one. Next slide, please. Now, of course, vaginal scan is more accurate, but Malaysian patients, many of them are very shy and they rather not have a vaginal scan unless really, really necessary. But we try to explain to patients. Sometimes they accept, sometimes they don't. But we will, as doctors, it's our duty to explain to them. Next slide, please. Do we need to do an X-ray? We need, if not pregnant. CT scan, yes. MRI, yes. But the MRI has a problem. If it's a moving part, it's not so accurate. Like that's why we cannot do MRI of the chest. It's moving, we are breathing, so it won't be accurate. Next slide, please. How often do we do a PET CT scan before we operate? Not often in Malaysia because we try to not overuse the cost of investigations. Usually we will make do with a CT scan alone unless really, really necessary before operation. After operation is a different issue. Next slide. So there are false positives to elevated CA125. If the patient is having her menses, it's not a good time to do the CA125. If there are fibroids, ovarian cysts, breast lumps, endometriosis, benign condition like adenomyosis or tuberculosis, and a few other conditions. Next slide, please. There are other conditions besides ovarian cancer that can cause elevated CA125, like primary peritoneal cancer. Ovarian cancer is one of them. Fallopian tube cancer, not common, but I've seen a few in my lifetime. Endometrial cancer can be elevated. Pregnancy can be elevated. Next slide, please. So if a person has gone for a screening test, which she goes for annually in some center and it's normal, the CA125 is normal, does it mean she has no ovarian cancer? You can't say that. Answer is no. We have to evaluate as a whole. Next slide, please. So in CA19.9, as I mentioned earlier, it can be elevated in patients with ovarian cysts in a few patients, not all. Next slide, please. So this is a picture of a patient with a complex ovarian cyst. She also had appendix removed and the omentum removed at the same time. It doesn't look grossly cancerous, but we had to remove it because she was in her 40s, but she didn't want a hysterectomy and her tumor markers were not that high. And clinically, it's not cancer, neither is it benign. So we had to wait for the report to come back first. Next slide. But we do know the older we get, the higher the chance of cancer. So if a young lady at the age of 25 comes with an ovarian cyst and a 70-year-old lady comes with an ovarian cyst, very likely the older person has a higher chance of ovarian cancer. Next slide. Of course, there are many of us who do not have family history of ovarian cancer or breast cancer. And if the person does get ovarian cancer, it's by chance. Of course, there are some patients where the grandmother had ovarian cancer, the mother had ovarian cancer, the sister had ovarian cancer, and the patient now also has ovarian cancer. That is by familial, not by chance. Next slide. Have we seen young ladies with large ovarian growths? Yes, I've now operated on quite a number of patients with large ovarian growths in young ladies, some as young as 16 years old, 19, 21, or not married, no boyfriend. Yes, fortunately, many of these are not cancerous, fortunately. Next slide. The youngest I've operated on is a 9-year-old girl who presented with a mass. It was an immature teratoma. I operated on her, gave her chemotherapy, and she's alive now, and she's doing her master's in the university. I last saw her about 1.5 years ago. I'm not sure whether she's married now or not, but she's still alive. Next slide, please. This is a combination calculation of the possibility of somebody having an ovarian cyst and cancer. It's called an RMI, risk of malignancy index. Is it very accurate? I won't say it's very accurate, but it's in the literature. There is evidence to use it, but I will not put 100% accuracy on it. Next slide. Well, very often we have to make decisions. Shall we wait? Shall we observe and scan again in 3 months' time? Shall we do a vaginal scan? Shall we do more tumor markers other than CA125? Shall we do a CT scan? Shall we do a laparoscopy? Shall we do an open operation? So these are all decision makings which we can only decide once we've done all the tests and after examining the patient. Next slide, please. So for ovarian cysts, of course, if it's not suspicious of ovarian cancer, no doubt laparoscopic surgery, keyhole surgery is the best. But as we know, it is very hard to diagnose early ovarian cancer. So there will be 1 or 2 where we will be operating on maybe early ovarian cancer with laparoscopic surgery if we are not careful. And we will have caused spillage in that particular patient. Of course, an on-table assessment, once we put in the laparoscope, can sometimes tell us whether it might be malignant or not. But having a naked eye and not having Superman eyes, sometimes we may be wrong. Luckily, so far, we have been correct, but sometimes it is possible to be wrong. Next slide, please. When we see patients with ovarian cysts, when we do not mention keyhole surgery, they will think that we are not good. So, like it or not, as a practicing obstetrician and gynecologist, we have to mention keyhole surgery as part of the options. But we have to be selective in which patient that we think keyhole surgery will be advantageous. And we have to be selective in which we will tell the patient why for that particular patient, keyhole surgery is not advantageous for her. And we will have to convince her if we need to, right? Next slide, please. This is a picture of an ovarian cyst. It's very small on laparoscopic surgery. Next slide, please. That one is a small nodule that you can see on the ovary. The ovary is whitish. The nodule is there. We biopsied it. It came out as some stromal hyperplasia. Next slide, please. This is a picture of a PET CT scan. Next slide, please. So the final determinant is it a benign cyst? Is it a malignant cyst? That is a final determinant. And we have to make the correct call in 99.999% of the time. That is the burden on the doctor, right? Next slide, please. But as a doctor, what we're worried about is spillage, if it's possible that it could be cancerous. So when we perform our duty of care as a careful doctor, we do not want spillage. Even if we use tissue bag during keyhole surgery, we cannot 100% guarantee there will be no spillage. So it is our ultimate responsibility that we want to avoid the situation if we can. So we have to be very, very careful when we select patients for open surgery or for keyhole surgery. Next slide, please. So if it's a real ovarian cancer, where the cancer marker CA125 is 1,500, when the ultrasound is really, really abnormal, when there's definite signs of cancer, she's lost 10 kilos in 2 months, she's cachexic, we need to do a midline laparotomy where we have to open in the center. We may have to remove the uterus and the ovaries. We may have to do tumor debulking, remove the omentum, which is a sanctuary site for cancer cells. And we will have to remove the appendix, which is another sanctuary site where the cancer cells will sleep. And if we didn't remove it, 5 to 10% of the time, the cancer cells can be sleeping in the appendix. And we will have to remove the lymph nodes, as well as any adhesions that will come along with the cancer, which is very, very common. Sometimes we have to ask our surgical colleagues to help us if there's bowel involvement, as well as a urologist if it's very, very stuck to the bladder. Next slide, please. So this is a picture of me doing laparoscopic surgery. We're actually aspirating a hemorrhagic ovarian cyst. Next slide, please. This is removing the cyst wall from an ovarian cyst that is benign. Next slide, please. These are the laparoscopic equipment that we normally use. Next slide, please. Now, one very important thing that I always tell the patients is the most crucial, which the CT scan cannot tell us, is the intraoperative on-table findings, right? And that is very, very critical for us because we know cancer marker is not very accurate. We know CT scan is not 100%. So what we see during the operation will tell us a lot of things. For some patients, once we put in the laparoscope and when we open up, we will know it's cancer. When we see it, we know it's bad. We know it is not good. For certain ones, we put in the laparoscope, we know this one is benign, for sure, right? So we also have a look around and make sure there are no other suspicious areas like concurrent deposits or deposits in the pouch of Douglas or in the liver. We always look at the liver and the bowel as well. And that will help us to decide. Before the COVID days, what I used to do, which I cannot do now because of COVID, I always ask our husband to come in to look at the specimen. And he makes a joint decision with me together. At the OT, he comes in for 2-3 minutes, not the entire operation. We show him, and then we tell him, look, this is why we need to do this. I think this is not good. I think she needs to have a hysterectomy. Then he will look, then he understands. If I tell him, look, this probably looks benign, and he has to look at it on table together with us, and we make a joint decision. That makes my life easy. But now with COVID, we cannot do that. Next slide, please. So is keyhole surgery the best? Yes, if it's benign. No, if it's cancerous. No, if it looks very, very suspicious. Of course, many patients will insist they want laparoscopic surgery. There's a small incision, there's less pain, they will discharge faster, you know, the cosmetic results are good, we get a good view, but sometimes we have to say yes, sometimes we have to say no. Next slide, please. So the final determinant is the exact nature of the ovarian cyst. Right, next slide. If I was a lady and I had an ovarian cyst, I would want my ovarian cyst to be removed intact and unruptured, and that is the best. Okay, because there's no spillage. No spillage. Next slide, please. So if it's cancerous and the patient is very young, supposing she's 36 years old, she's not married, she's got no children, we can do conservative operation. We can, if we need, or if possible, we remove the cyst or the ovary on the affected site. we remove the omentum, the appendix, we clear the bowel, the pelvic nodes, but we don't remove the uterus and the other ovary first, unless it is involved. If need be, we biopsy the other ovary. Then we close up, we wash up, and then we wait for the final details of the report before we decide to remove the uterus or not. And sometimes we may find that we may not need, because the cancer has been cleared, and it may be a very early stage 1 with well-differentiated tumor, and that's all we need to do. But of course, the patient may need certain other things. Of course, if the patient is older, who's in the 50s, 60s, 70s, of course, it is best to remove everything so that we do not need to come back in and operate again, unless the patient wishes so. There are many women who are in their 48, 47, 46 who don't want the uterus removed. But we tell them, if you don't want, if the report come back as no good, then you end up with a second operation. Some patients, they don't mind. They want to take a chance because they want to keep the uterus. Right, next slide, please. So the important thing is, when we do operation for early ovarian cancer, as well as for late stage cancer, is the tumor clearance. The tumor clearance must be good. If the tumor clearance is not good, then it gives more work for the chemotherapy when the report come back and confirm it is a cancer. So tumor clearance is very, very, very important. That's why an operation can take 2 hours, 3 hours, 4 hours, sometimes 5 hours. And we have to meticulously reduce the tumor volume to a very, very, very low volume. Next slide, please. As I said before, why the appendix and omentum need to be removed is because very often, without us suspecting it, there are very, very small cancer cells that are sleeping in the appendix and omentum. And if your surgeon did not remove it, the chance is the cancer may come back from the omentum and the appendix. So that's why we have to remove. Although it may sound strange to the patient, but it needs to be removed. Next slide, please. Why do we need to remove lymph nodes? Well, if we didn't remove the lymph nodes and there were cancer cells in the lymph nodes, it will come back in the lymph nodes. And if we give chemotherapy after that without removing the lymph nodes, it is very, very hard to cure cancer in the lymph nodes. And it's faster to remove it together with the whole lymph node. And radiotherapy to sterilize it is not an option in ovarian cancer. It doesn't really work. So that's why we have to remove the lymph nodes, because very often we don't want to understage the cancer, right? That's why it's important to operate with somebody who knows how to remove the lymph nodes clean, so that you do not have left behind disease. It is very hard to remove the lymph nodes in the second or third operation. They'll be stuck. They'll be very, very, very sticky, and they may be stuck to the blood vessel, and it's impossible to remove the lymph node when it's stuck to the blood vessel. You'll tear the blood vessel. The first operation is always the best. Next slide, please. So when we have ovarian cancer, we always stage it: stage 1, stage 2, stage 3, stage 4. And the management is dependent on the stage, although they most of the time get chemotherapy, except for very, very well differentiated stage 1A cancer, which is well staged. Why do I use the word understaged? I use the word understaged means if you had an ovarian cyst and it looked benign, and the surgeon only removed the cyst and nothing else, but the report came back as cancerous, then you will have been understaged. That means you didn't take the omentum, you didn't take the rest to check whether there's cancer cell. So that means when we assume it's a stage 1, it might not have been a stage 1. There might be lymph node involvement, meaning it is stage 3. So the management subsequently will be wrong. Next slide, please. Can we compromise? Actually, we cannot, because the cancer cells are actually little devils, They will never listen to instruction. They will never listen to reason. They will never listen to anybody. And they will do what they want to you. So therefore, when it comes to a cancer or a possible cancer, we cannot compromise, because compromise may mean that your own health will be affected, and your own longevity, how long you live, will be greatly, greatly affected. So compromise is not possible if it's malignant or possibly malignant. We have to be very strict about that, because it is not negotiable, unless you want the surgeon to do less and not the best. Next slide, please. So in summary, if it's benign, do manage as benign. If it's suspicious or cancerous, cannot compromise. Cannot compromise because you are compromising with your life. Okay. Next slide, please. Next slide. So in a short summary, ovarian cysts can be physiological, can be benign ovarian cysts, can be borderline malignancy, which is another lecture, can be a well-differentiated tumor, can be a moderately differentiated tumor, can be poorly differentiated, which is bad, can be aggressive, poorly differentiated, can be a germ cell tumor, can be unclassifiable. Next slide. Next slide. Next slide, please. It could be. So the other thing we need to do is once the operation is done, we need to confirm the diagnosis. I have seen a patient who was operated for endometriosis, a young lady who's in the 30s. And the doctor immediately gave during the operation, they saw chocolate cysts, they saw dark endometriotic deposits. So they didn't trace the report, you know. And they gave her medicine for endometriosis straight away. The patient came for second opinion, and then I asked them, can you please get me the report? And when she got the report from the hospital, actually it wasn't endometriosis. It was an ovarian cancer, endometrioid adenocarcinoma. And she was very shocked. But the report showed what it showed. It wasn't endometriosis. And it was a surprise to her. But luckily, we insisted on looking at the report. So always insist on looking at the report. Very important. Huh? Next slide, please. So what chemotherapy do we need to give? It is cancer, ovarian cancer. Of course, ovarian cancer can also be from stomach cancer that jumped to the ovary. You know, it could be a large intestine cancer that jumped to the ovary. So it doesn't mean it is always from ovarian cancer. Doesn't always mean that. So of course, if it is ovarian cancer, we need to give the chemotherapy for ovarian cancer, which in many instances is carboplatin and paclitaxel. And do we need to do BRCA testing? There are many drug companies that want us to do BRCA testing, which is good because then you will be able to use some other drugs like, you know, PARP inhibitors and all that. But the problem with doing BRCA testing is once it is tested and the patient is tested positive, the insurance will decline to cover anymore because they'll say this is congenital, you know, they won't cover. And for us to do the BRCA testing and not reveal to insurance company is not ethical also. So it puts us susah, you know, and the patient also susah. So that is the dilemma. Huh? There's also some patients will use bevacizumab, which also has good effects and bad effects. Huh? So chemotherapy is required. The response rate for chemotherapy is quite good if it's responsive. It's about maybe 60 to 80%. Right? Some even will calculate up to 90% the initial response. But will it come back or not? Sometimes it will. Next slide, please. Recurrent ovarian cancer is another ball game. I think we will not go into that today. Next slide, please. So it's very important to explore the management options. I have seen a patient who was operated in a very big center in Subang Jaya. She was diagnosed as ovarian cancer stage 4. They didn't offer her any treatment. They just told her to go home. That was in 2-3 years ago. But today she's still alive. She came to see me for second opinion, and we started her on some medication which she never had before, and she seems to be responding very well. Okay. Of course, she's still stage 4, but is it ethical not to offer treatment or not? That one I don't know. I'm not sure what's the reason for them not to offer treatment, but they didn't offer her anything. Next slide, please. Okay, I need to acknowledge everybody who helped to make this lectures successful. It takes a lot of background work, and I'd like to thank everybody, especially my mentors and my dean, as well as Prof. Thomas and all my colleagues, and to all the patients, and to all the Taylor's University Medical Society members who are involved in this lecture series. We will be having another one in October and November. Thank you very much. Next slide, please. Next slide. So can we treat early ovarian cancer? The answer is yes. Can we treat late ovarian cancer? The answer is yes, we can. But we must try to detect early, and we must listen to the doctor as to what he says, because he has more experience than you as a single patient. Thank you very much. Thank you very much. Okay, I can take any questions that there may be. Yes. Are there any questions? Are there any questions? Anybody? Somebody asked why in early pregnancy the cancer marker can be high. Alpha fetoprotein is elevated in pregnancy. CA125 is elevated in pregnancy. So these are well known now. Beta HCG, of course, is elevated in pregnancy, but these are common natural things that we cannot do anything about. Of course, they confuse us in the confusion as to whether the patient has cancer or not. But most of the time, if you check 100 mothers who are pregnant, it will be elevated anyway. Any other questions? Anybody? I will be happy to answer any question. Okay, somebody asked, is caring for breast and gynecological issue like this, is it just hang on, let me see the question. Let's hang on. Go back in. Okay. There are many doctors who will see patients with breast problems, and many patients who will see patients with ovarian cysts, including general practitioners, some surgeons. So it is going to be channeled to whichever doctor that is supposed to be the specialist to care for the patient in the end now. But many doctors will see, right? So we are here to learn as well, so that we will manage the patient correctly. I don't think there is any hard classification of who the patient belongs to. The most important thing is the patient's welfare and well-being is taken care of. Any other questions? Anybody?
Thank you, Prof, for the informative lecture. I'm Anita here.
Yeah, okay, no problem.
I would like to ask you one question. Whether you enrolled any patient for trial? Have you used monoclonal antibody for ovarian malignancy, which were...
I don't think being in private practice is very hard to enter anybody for trial, because when you enter somebody for trial, that means the trial has to pay for the CT scan and the drugs and the complications and the blood tests and all the GCSF that they require, And I don't think there's any such a rich person or organization to be able to afford this. The studies in America have got very big budgets. They got 300, 400, 500 million US dollars. Studies in Malaysia have got very low budget, because in the US, the drug companies sponsor a lot of these studies, and they don't come to Malaysia sometimes. They will stay in the US. So I cannot answer your question, because there's very little that has been proven 100% about these. Okay. Any other question?
One more question, Prof.
Yes.
Could you please share your experience of using monoclonal antibody therapy for ovarian malignancies? Some recurrent malignancy, they are not responding to chemotherapy. And
it's a good question, but fortunately, so far, many of them respond now to the normal standard chemotherapy, you know.
Mm.
And monoclonal antibody is not cheap. How
Mm.
many patients can afford it? No? Not many patients can afford it, even if it's indicated. Very few can afford it. Okay?
Okay, Prof.
So
Oh, okay,
it's a
Prof.
question of cost, lah. It's a question of cost, right?
Oh, okay, Prof. Thank you.
Thank you. Yeah. Any other questions? Okay. If there are no questions, I just want to update that we will be having another talk next month on PCOS, fibroids, as well as the radiological findings of PCOS and fibroids in October this year. We will also be having another talk on in November 2021 on menopause, on eye problems in pregnancy, and on hemorrhoids in November. So you can always message me or Prof. Ganesh or keep in touch if you are interested to listen to the next talks. Okay, I think Prof. Ganesh has left. So if there are any questions, I'll answer them. If there are none, I think I will say thank you.